Welcome to Cancer Healthcasts, where science is driving hope. I'm your host, Catherine McPhail, and today we are joined by Dr. Paige Green, who is the Chief of the Basic Biobehavioral and Psychological Sciences branch at NCI. We'll be discussing the relationship between cancer and aging and the current state of research for healthier survivors. Paige, thank you so much for joining us on the show today.
Oh, thank you so much for having me. This is a great opportunity.
So to start us off, could you speak to the relationship between cancer and aging and what attention you hope that additional research will bring to this area?
Oh, thank you. It really is a pleasure to talk to you today about cancer and aging. But before I get into that, I really want us to think about population aging in the U.S. So our EPI data shows us that that our 65 and older population in the U.S. is projected to nearly double in size in the coming decades, from what was 49 million in 2016 to about 95 million in 2060. And so as a result, the proportion of people aged 65 and older will grow really from 15% in 2016, which was some time ago, to nearly a quarter of our population in 2060. And what's more important is that the number of people 85 years and older is expected to double by 2030 and triple by 2060. So population aging as we know it is a major demographic transition, and longer lives or living longer really affords great promises and opportunities, but also emerging challenges. So I like to set the stage when I talk about cancer and aging, really setting our understanding of how our population is living longer overall. So why should that be of concern to someone like myself who's at the National Cancer Institute? Well, everyone knows that that aging and cancer appear to be inextricably linked. Our EPI evidence points to chronological age, specifically advanced age, being the largest risk factor for most cancers that we see in our human populations. But what's really important is that the relationships between aging and cancer are multi-directional. We know that aging increases the risk of developing cancer and non-chronic diseases, and many of those non-chronic diseases, say like lung disease and diabetes, further increase our cancer risk. So cancer and other chronic disease also promote additional aging, each contributing to the quality of the survivorship of our cancer survivors. So we may see things like reduced functional ability, some geriatric syndromes, and actual death. So, when you think about cancer, I don't know what comes to one's mind, mental model or mind's eye of a cancer survivor or someone who's diagnosed with cancer survivor. And I use cancer patient and survivor somewhat interchangeably because, at least from NCI's perspective, we consider someone being a survivor from the point of diagnosis. But my point in raising this is that the median age of cancer diagnosis is 66 years. And, from a societal framework, we consider those 65 and older as older adults. And of course, the median age of cancer diagnosis ranges from, for the common cancers, ranges for like 62 years of age for breast cancer, all the way to like 71 years for lung cancer. And this is really great news in part, and you may be shaking your head saying, what? But that's because the cancer death rates continue to fall and decline. So we are really at a point in our history in which, even though we have incidence of cancers that increase with age, that we are really, our treatments and other things are allowing our cancer survivors to live longer. So what does all of this mean in terms of like how many within our U.S. population are actually surviving with cancer? Well, my colleagues at the at our surveillance research program, along with the American Cancer Society, recently estimated that there are about 18.1 million cancer survivors, and of those, 67% will be age 65 or older this year. And that by the year 2070, 74% of cancer survivors will be age 65 or older. So I'm really hoping that that this podcast will just highlight for federal employees and others that might be happening to listen about just the real impact that aging has on our survivorship population.
Absolutely. I mean, there's so much you just mentioned to dive into about how you say, the aging population in the US is going to double in size, how there's sort of a feedback loop between cancer and aging and the relationship between those two things, and how this is really a growing area of research and also a growing area of importance because, the sheer number of older cancer survivors is going to increase so much.
Right. And there are other aspects to why it's important, which I think, maybe we'll get into later. Things like just as we consider our older population, we really need to think about how we approach and treat cancer and sort of support cancer survivorship really from, a lifespan perspective. We tend to know that, our pediatric and childhood cancer survivors are at one end of the vulnerability spectrum, and then our older cancer survivors are at the other end. And they both have physiological, biological differences that make them vulnerable and that make our approach to treating them, I think, somewhat unique.
I'm wondering if you could tell us more about why it is important to learn more about how cancer survivors age compared to how the rest of the population ages.
Oh, yeah. So, when in hearing that question, I also am a stress researcher, and when thinking about stress and cancer, I've heard biological scientists and clinical scientists say, "Well, why study stress in the context of cancer? Because we're all stressed, right?" And so, yes, we all age, and but there's considerable heterogeneity and variability in how we age. So, from my particular perspective, our interests are not limited to chronological age, really. As you and members of the audience might know, that chronological ages is really just based solely on the passage of time. So it's the person's age in years. But chronological age has limited significance in terms of health. There are other types of aging that have implications for cancer survivors and everyone else, quite frankly. So we can think about something like subjective age, which is based on how people act or feel. And, if we were having, either a live discussion or one in which we could use pictures, I would show you, how someone at 85 in one condition looks completely different from someone who's 85, another person. We also know that measures of functional capability determine how we are able to function in our body. So that's something that we like to refer to as functional age. And then there's also biological age, which refers to changes in the body that commonly occur as we age. But because these changes affect some people sooner than others, some people are biologically old at 65, say, and others are not and may not appear biologically as relative to the first person until a decade or more later. So we know that there are noticeable differences in apparent age among people of similar chronological age, and it could be caused by things like their environmental exposures, their lifestyle that they've engaged in historically over time, their habits, and maybe even subtle effects of disease rather than by differences in actual aging. So aging is really a process that's defined differently by different scholars. I offer for our consideration, Kirkwood and Osted's 2000 characterization of aging as really a progressive loss of function that's accompanied by decreasing fertility and increasing mortality with advanced age. And I also offer the working conceptualization that doctors Jennifer Gaida, Lisa Galicchio, and I use as we guide our work in cancer survivorship and aging. We really see aging as a dynamic interplay of biological, physiological, environmental, psychological, behavioral, and social processes. So our lifespan perspective on aging attempts to understand the whole survivor. And you may be familiar with an IOM report many years ago that sort of talked about cancer care for the whole patient. So it's sort of, we're attempting to understand cancer care for the whole survivor. So we're interested in the life that they brought with them to treatment and the context which shapes their lived experiences as survivors. And we're a team of colleagues that are trained in anthropology, epidemiology, and psychology. So we really see variability in human aging as closely related to the social determinants of aging.
Right. And it sounds like there are so many complex factors to understand. And then this bigger question about, what might medical intervention look like? You mentioned that stress is a major factor in aging. I think we can all understand that cancer introduces an immense amount of stress.
Sure.
Are there specific treatment considerations for cancer survivors as they age, and how might mental health and psychosocial concerns be addressed in the aging population of cancer survivors?
Yeah, so as you may recall, I mentioned a bit earlier that the median age of a cancer diagnosis is 66 years, and we're challenged to consider whether individuals at older chronological, biological, or functional ages have unique needs and characteristics that should be considered in treatment decision-making. However, I am not medically trained. I'm a PhD, so I really refrain from answering your question clinically. However, I can offer the perspective that aging cancer survivor populations are observed to have complex healthcare and medical surveillance needs. In 2006, the former director and my former colleague of the NCI Office of Cancer Survivorship, Julia Rowland, and a woman that I consider a tour de force that nearly single-handedly started the International Society for Geriatric Oncology, and that's the late Rosemary Yancek, wrote a commentary that stated that we must understand and find ways to reduce the adverse impact of surviving cancer on the health of older adults. Mm-hmm. So I was blessed, many years ago to have had the opportunity to know and work with the late Dr. Arthi Huria. Her life's work as a medical oncologist trained in geriatric medicine was to understand how aging impacts the experience of cancer and cancer treatment, and conversely, how cancer and its treatments impact the experience of aging. So she characterized her older survivors as coming to her, having polypharmacy, multiple comorbid chronic conditions, mild cognitive impairment. Many were presented to her as being pre-frail or frail, needing assistance with daily activities, limited social support, and living alone. And of course, this does not characterize all older individuals or all older individuals that will be diagnosed with cancer, but that is what she primarily saw in her clinical experience. And, in a recent review of the challenges of survivorship for older adults diagnosed with cancer, Fitch and colleagues, I think this was just published earlier this year, synthesized evidence and highlighted that on average, older adults with cancer take nearly 10 different medications, and that we must consider the impacts of adverse drug effects like falls and cognitive issues, and also consider that drug and disease interactions can be severe. So, older patients and survivors also have a higher burden, like I said, of frailty, mobility limitations, comorbid conditions that also can bring about a lot of stress and fatigue. And they also have a greater risk for other physical and cognitive impairment when we compare them to cancer-free controls. We found, my colleagues several years ago found, that poor physical and mental health related quality of life was reported in about 25 and 10% of survivors. And that's relative compared to 10% and 6% of adults without cancer. So, depression, anxiety, different types of existential issues can definitely come about when you are dealing with a life-threatening disease, and even when you are dealing with a disease that changes over time. So we haven't even considered the new sort of emergence of survivorship populations that are important, and those are those survivors that are living with advanced and metastatic disease that deal also with uncertainty and prognostic unawareness or prognostic uncertainty as well. So definitely many psychosocial issues that need addressing. And it's not only within cancer, I think it's within any chronic condition which presents a threat to life.
Absolutely. And you mentioned comorbidities, and I was wondering if you could speak more to why it's important to consider pre-existing comorbidities or conditions that arise during treatment and survivorship, and sort of some of the downstream implications 10, 20, 30 years after treatment.
Yeah, well, for the most thing, I want us to consider that comorbidities influence treatment, right? Comorbidities it influences treatment decision making. It influences follow-up care. It influences the complexity of care. Many cancer patients and survivors do not present with that being their only health concern. So it requires coordination and consideration of not only managing effectively the cancer for cure or control, but also managing effectively the comorbidities that may have pre-existed before their diagnosis, or that may come to clinical awareness during their survivorship journey. So it requires also considerable complexity of medication adherence, self-management. And one of the things that we haven't talked about yet are even the caregiving complexities. So as we know, cancer does not only affect the person with cancer, it affects their families, it affects those that provide care. And so we even know that if a caregiver has their own set of comorbidities or has, other psychosocial issues and concerns, that there is some, interrelationship between both the survivor and the caregiver. So that is also another area of emerging importance that my colleagues at NCI and those in the academic community are paying attention to. So, you asked about the impact, I believe, of cancer treatment, 10, 20, and 30 years away from initial treatment. And I must say that this is not all doom and gloom. I really want to highlight that we are living really in the best of times relative to the past. Our cancer survivors are living longer, and that is like a hallelujah moment. So, our estimates as of 2022 are that 69% of our survivors have lived at least 5 years or longer since their diagnosis. 47% of survivors have lived 10 years or more, and 18% of our survivors have lived 20 years since their diagnosis. So we really do need to celebrate the tremendous advances that allow our survivors to age chronologically. Mm-hmm. And I have really unrelenting optimism that the quality of survivorship following cancer and cancer treatment will continue to improve. That's why we have significant investment in cancer survivorship research. However, we are still aware that, our cancer treatments cause long-term and late effects, but still, my institute, NCI, the FDA, industry, and other organizations are, really burning the midnight oil to develop targeted therapies that will minimize off-target effects, and the emergence of what we like to consider the aging phenotypes that arise because our conventional treatments are known to affect the underlying hallmarks of aging.
That's great to hear. And it's also always great to hear about, as you mentioned, sort of this growing attention and research area to caregivers and their role in cancer survivorship. There's a lot of encouraging work being done, especially as you mentioned, around more targeted therapies and reducing adverse effects from treatment.
Yes, and I want to also raise that, we have entered into an era, well, we've been in it a while, but an era of, sort of the emergence of informal caregiving, right? We've transitioned a lot of our treatments so that they are, presented as maintenance therapies, or that they're given orally. The complexity around that type of management can be mind-blowing. And so we must really give credit to caregivers that are really in the trenches, supporting those, our survivors. And, our caregivers are aging as well. And come to the caregiving situation with their own concerns. So we sort of consider cancer caregivers as secondary survivors, and they're secondary survivors that are aging as well. So we definitely also want to pay attention to their health, physical and mental well-being.
Absolutely. I mean, it's a disease that affects so many people. It's great to hear how that's really being looked at. You mentioned that this is your passion, that this is a passion area for you. And I wanted to ask what brought you to this field and why is it important to you?
Way back in, I think, 2013, there was a paper published in JAMA that I read that really knocked my socks off. And it was a paper that was looking at the late and long-term effects of adult survivors of pediatric cancers. And there is a particular quote in that paper that really brought me to aging as a focus. And if I think I can remember it, it's sort of like, considering that maybe the median age of this cohort that they studied was 32 years old, the data that they show in terms of the prevalence and the gravity of the sort of adverse health outcomes was staggering, and really pointed to a pattern of accelerated or premature aging. So I actually came to an interest in aging thinking about, oh, well, yep, I want to study accelerated or premature aging in AYA survivors or pediatric survivors. And it was actually Arthi that convinced me, Paige, in order, in order to see those types of things that are observed in the younger survivors, you literally do have to wait 20 or 30 years. But there is, although complex, there is another population, and that is our older population that I see, that she saw in the clinic, that really can showcase how our treatments may, although with curative and control intent, are leading to unintentional consequences. So that really lit a fire in me, and I was able to work with her, and she mentored my then at the time postdoctoral fellow, Dr. Jennifer Gaida, who is now a colleague. But you may also ask me, how did I end up in cancer overall? I was actually trained as a cardiovascular researcher, and one that was very much interested in stress and lived experiences, and how it affected sort of the hemodynamic profiles that are associated with cardiovascular disease. I then transformed that interest into thinking about stress, and how stress through neuroendocrine regulation might impact cancer progression. But at the heart of it, I am trained as a clinical health psychologist. And so for me, I come to this, although I don't have a clinical practice, I come to this thinking about, how do we support research that helps us understand how we provide cancer care for the whole patient, right? And how do we think about the social determinants of health, that for many people like me, and those on the podcast might not know that I am a scientist of color, that, my mother, when she was diagnosed, and my aunt, when diagnosed, were in some ways disadvantaged due to structural inequities. So it's really important to me to, understand the science of healthy aging and survivorship research that not only focuses on, those that have the resources and those that are not those that are not well resourced, but thinking about research that focuses on preserving functional ability and preventing loss of capacity. So it's important to me, really, to encourage research in this nexus that, without compromising cure or control, really helps us preserve or restore optimal quality and duration of life, and enables our survivors to live long, healthy health spans, right? That enable them to engage in the things that they value. And this is so connected to the NCI mission, which really strives to support, the advancement of scientific knowledge to help all people live longer, healthier lives. And for me, living longer, healthier lives means that we have to pay attention to and care about the quality of aging amongst those that we treat and cure for cancer.
I really appreciated that story you shared about how this paper was a catalyst for you. I think when you're putting your work out there, you never know what's going to strike someone. So that's right. That's a really great story.
Yeah, it is. What's even fascinating is, forward, I don't know, almost 10 years, I was able to work with my most brilliant, at the time, postdoctoral fellow, Jennifer Gaida. And she is, in the throes of finishing up a paper analyzing data on accelerated aging and biological aging in the same cohort. And so this is the first time that I have actually seen my interest in a way come full circle. So thank you for pointing out the significance of that paper. I've just even seen it in a different way, just through us talking.
Oh, this is great. Wow. That's wonderful. Is there anything else that you would like to add?
I hope that the audience takes away that NCI is really interested in understanding the nexus between cancer and aging, not only from a biological perspective, but also from a lived survivorship perspective. We really want to be able to support the growing survivorship population to not just live longer, but to live with health, right? However that may be well defined for them. And so it's no longer, yes, of course it is about life expectancy, but, we also have to consider the societal trends that we are coming up against. We are working longer. We are contributing to society, in many different ways as we age. And so it really is our responsibility to, cure and control, but to also be concerned and to work with colleagues that are in other disciplines or have other research foci to sort of think about how we can work together to make sure that our survivors, don't survive from cancer, but then die from congestive heart failure due to treatment, or die from diabetes or things like that. So it really is thinking about the whole survivor. And while at NCI, of course, we have to have, the sort of laser focused emphasis on, cure and control. We also need to think about multimorbidities and the ways that our survivors come to us in ecologically valid ways, and that our treatments must be administered outside of a clinical trial environment with real people that are aging, that are loving, that are engaging, that really want to thrive despite a diagnosis of cancer. And so we're now at the age where for some cancers, it's going to be more of a chronic disease management, some may say. And so, just trying to stay in line with the pace of how our treatments are allowing survivors to age considerably longer. And in that vein, we want them to also be able to age in a healthful manner. Absolutely.
Well, Paige, thank you so much for joining us on the show today. This has been a really fantastic conversation.
Oh, thank you for having me. Thank you for having me. And I want to just end by, just acknowledging all of my colleagues at NCI that I co-labor in this work with. But I hope that I have represented our perspectives well. And I hope that I have generated some interest in our older survivorship population.
HealthCast, along with GovCast and Cybercast, is a production of GovCIO Media and Research. For more podcasts and to check out the other shows, head to govciomedia.com. Watch out for new episodes released every Tuesday and Wednesday across our shows. You can follow all of them in your favorite podcast platform, and if you like what you heard, make sure to let us know by leaving a review. And if you have any topics you think we should look into, contact us at newsletter@gcio.com.